an introduction for GEM and what it is. So I'm Stephen Fort. You can call me Steve. I'm a physiotherapist. I've been a physiotherapist for quite a while, since 2013. And when I finished like my basic physiotherapy education, I was working with some elite physiotherapists, like some very well-educated, well-trained physiotherapists that share the set of credentials that I currently have. And so I worked with people who were specialists. I worked with people who had been through a fellowship program. And in doing so, I came to realize how little I knew, that even though I just completed a doctorate of physical therapy from a very prestigious physiotherapy school here in the United States, Texas Tech University Health Sciences Center, that my effectiveness as a therapist, my comfort with working with patients, with making diagnoses, with treating effectively, it just wasn't there. And I'll never forget, I think probably one of the things that tipped me, that really pushed me to take the next step, was I was working with Dr. Kelly Wilson. She was my mentor and clinical instructor, and we had a couple of patients that I had seen this patient who had pain by his shoulder blade. He was a military guy, probably about 40, 50 years old. And we had been doing all of the stretching, all of the thoracic mobilizations, all of the exercises that I had in my toolbox. And this guy was not getting better. So after 3 or 4 visits, I did what I think any good therapist should do, is it's time to start asking questions. So after 3 to 4 visits, I brought Kelly over and said, Kelly, this is what's going on. This is what I've been doing. And I'm not even joking. She spoke to him for 2 minutes. She laid him on his back. She cracked one of his ribs. She manipulated one of his ribs, and he got up and kind of moved his shoulder a little bit. And he's like, okay, my pain's gone. Like, pain is gone. So at that moment, I was like, I need to know what she knows, and I need to have the same skill set that she does, because I cannot be going around being an ineffective therapist, right? We cannot fix everybody. Patients will come to you, patients will come to me that we cannot make better, or that we cannot make better all the way. But there are so many patients that I see, that Dr. Singh sees, that everybody sees, that the more educated you are, the better the experience you have, the better you can treat that patient, the more effective you'll be, the better you will enjoy your job, the better your patients can, heal and improve quicker. I think it also does a lot for the reputation of the clinic, of the business, and stuff like that. And so for me, it's about the patients, and it's also about the ability to enjoy my job. I don't get anxiety anymore when a patient comes and I'm like, oh, like, what's going on? What can we do? Like, are we going to make it worse? Are we going to make it better? Every day, like, there's not a single patient that comes in here where I'm scratching my head and don't have at least a good idea of what's going on and where can we start this patient. And so that's what becoming a specialist and going through fellowship program did for me. And so Dr. Singh and I are very passionate about this. And we want to take this level of knowledge, this level of education, this level of effectiveness, and we want to bring it to physios all around the world, I think that a physiotherapist ideally should be the best place, the singular best place, most effective place that somebody can go with pain and get everything that they need. And so we kind of have a hybrid model, or a hybrid philosophy, where physiotherapists should be great at exercise and stretching. They should be great at manual therapy, which is mobilizations, muscle energy techniques, manipulations, kind of the osteopathic based stuff is where we get a lot of that. And then dry needling, potentially. There are times when patients might benefit from dry needling, which is Western medicine's version of acupuncture. And so, we're trying to put together this program where we offer a 1-year cohort. You guys join on, you take the classes with us. There will be quizzes and exams and hands-on trainings along the way. And it's a brilliant 1-year experience to propel yourself into your profession, to become a better physiotherapist, and potentially become someone who can mentor other PTs, and maybe even host some of our future students. We're looking for people to become leaders within our network that we can have, students go and spend time with and spend hours with as kind of like a fellowship training, kind of like a hands-on training. So more information on that to come. But basically who we are is we're looking to create the next generation of expert manual physical therapists and all that encompasses. It's not just about popping and cracking. It's not just about needling, it's not just about exercises. It's really the best combination of all of these things. And most of the research that we have in the United States for this condition, for this diagnosis, for this injury, most of the research supports that manual therapy and exercise combined is going to be the best combination, the most effective interventions that we can provide. So that being said, let's go ahead and jump in a little bit. Yep.
This is who we are. So I met Dr. Steve back in 2013, and I think we worked together for 4 or 5 years, I guess, right? 5 years almost.
Yeah.
And
5.
And I think we're very passionate about this project because we feel that with this advanced education, we can bridge that gap between elementary education, which is BPT in India and DPT in the United States. And so that you can combine the clinical evidence, clinical reasoning, and cutting edge hands-on skills. So you can provide probably the best care which you can provide to your patients. And the idea here is that the research, the evidence keeps evolving. We keep finding new markers, new clinical prediction rules, and new treatment methods to enhance and update our skills. And once we graduate college, I think sometimes it's hard to update that. And I think that's where this program comes along, where we've added a lot more information, and we'll continue to add more information as we go along, because I think learning is a continual process, right? Learning is a continual process. And we are in such a fast developing profession, because the way we practiced 10 years ago, or maybe like 15 years ago or 5 years ago, we're practicing very differently. I have evolved as a therapist because what we thought was very effective and evidence-based treatment method is redundant right now, right? So the idea of this program is to bridge that gap between your elementary education to a kind of a postdoctoral level education. And in the US, fellowship programs and manual therapy fellowship programs, which is offered by AARMT, which is, I think, our parent body, American Academy of Orthopedic Manual Physical Therapists. They call it a postdoctoral fellowship program. So it's going to be a very intense program. And AARMT wants the program to be at least 1 year, and that's the minimum length of the program. Some programs go from 1 year to 3 years. So you can do it from 1 year to 3 years, but the minimum length of the program is 1 year. And that's what we are offering, like 12 modules, and then 16 days of hands-on training. We divide it into 8 days of hands-on training. Yeah. Mm-hmm. Dr. Ford, I think we should start and talk about the topic, and then we'll talk more as we go along.
Yeah. I wanted to show this really quickly. Our tech guys put this together, and it's brilliant. This speaks to, some of what we do, certainly not all of it, but I'm going to go ahead and just show this video real quick. Awesome. And I'll share the contact information at the end of the lecture today. So I'm going to just wrap up talking about myself and Dr. Singh, and then we're going to jump in. So after a doctorate of physical therapy, I did 2 years of specialization, which is basically you're practicing and studying to take this big bad exam in orthopedics. So I've completed that. That includes every single joint, every single body part. So from TMJ all the way down to the ankle, foot, toes, hands, everything like that. And that's an advanced level of education. And then the fellowship program, you know, that Dr. Singh and I did, and Dr. Singh actually did too, but the fellowship program that we did is an additional basically 2 to 4 years of hands-on training, and then working for 440 hours underneath the best of the best physiotherapists in the USA. And so I think that we bring a lot to the table, and I hope that you guys will enjoy it. Another goal for me is that we make this fun, not like entertaining or fun, but just like interesting. We want you guys to be interested, to be engaged, and, you know, ask questions and stuff like that. And so I think that we really bring a lot to the table. Let's jump in. So the chosen topic for today it's one of my favorites. I love anything that talks to like double crush or diagnoses that go around. And I see this all the time, but I have so many patients that are referred to me for plantar fasciopathy, plantar fasciitis. And that's what it says on the script. And the patient comes here, the doctor says, this is what you have. The patient's telling me this is what I have. And I have to slow the patient down and say, did the doctor put his hands on you? And they say, no. I say, well, we don't know what it is yet. So let's wait and see. Let's wait and see, because there's lots of things that it could be, as you guys may already know, or certainly will learn today. And so there's many of these diagnoses where, you know, we commonly treat, you know, foot pain, but there's so many different causes of it. So at GEM, we want to teach a robust differential diagnosis for things like lateral elbow pain, medial elbow pain. You know, how do you treat carpal tunnel syndrome? How can a rib dysfunction cause pain in the upper extremity? How can a low back issue or a sacroiliac joint dysfunction cause plantar foot pain that gets called plantar fasciitis? And then if you treat it like a plantar fasciitis, you're actually wasting your time and the patient's time. And we'll talk about why that is in just a minute. So the agenda for today is we're going to talk a little bit about some anatomy and biomechanics. We're going to talk about what are some of the things that the patient will report to you subjectively that should get you thinking, this does not sound like plantar fasciitis, or this does not sound like plantar fasciopathy. We'll talk about some tests and measures, special tests, and then treatment. Excuse me. All right, so for the anatomy and biomechanics, let's talk about anatomy. So I like to call this the 1-inch window. And within this 1-inch window on a patient's foot, there are many structures that can potentially cause pain. The main two that we're going to talk about today are the plantar fascia and nerve. So a branch of sciatic nerve becomes the posterior tibial nerve, and then the posterior tibial nerve runs along the medial foot with posterior tibial tendon, and then branches to medial calcaneal nerve, to underneath the foot, to Baxter's nerve, lateral plantar nerve, medial plantar nerve. And so this and your plantar fascia are so close. They're so close together, and the symptoms that they give are quite similar. And plantar fasciopathy is often mistaken for this nerve issue, okay? So you can have plantar fasciopathy alone. You can have this nerve entrapment alone, or you can have the two of them simultaneously. And it's quite frequent that this will start off primarily as a nerve issue, and it can be driven and become a plantar fascia issue, but it can go the other way around as well. And we're going to talk about how can that happen, the biomechanics, the neurokinetic chain. We're going to jump into that here in just a minute. Dr. Singh and another physiotherapist actually did this case study that was published about what we're talking about today. So it's very interesting. If you guys want to check out the reference later, you sure can. And so a lot of times when we have neural entrapment or neural symptoms in the medial ankle and foot and the plantar surface of the foot, it gets coined as tarsal tunnel syndrome. And we're going to differentiate what is that, and then what's proximal tarsal tunnel syndrome and what's distal tarsal tunnel syndrome, because the symptoms for those are actually a little bit different. And Dr. Singh will be talking about that in today's lecture a little bit later. Let's talk about the biomechanics. So, anytime we get a big group of physiotherapists from all over the world, someone in UK, someone in Rwanda, lots of people in India. I think we've got some therapists from the US as well. I invited a couple of my, friends and counterparts to jump on. But anytime we get a big group, it's difficult to know how much everybody knows. And so if this is basic for you, hang tight for a second. If it's complicated for you, I have literally in this slide put down this series of events, and so you can reference it, chew on it, and stuff like that. But let's talk about the biomechanics. And this is, I would say, pathomechanics or bad mechanics. What we're demonstrating in this slide is abnormal, aberrant mechanics. There's weakness, there's compensation, there's stiffness, there's some kind of issues that are contributing to poor movement. And so let's talk about it. So let's start with midfoot collapse or ankle pronation, right? We've all have patients that are pronators. Maybe they have a rigid flat foot, maybe they have a flexible flat foot, but we all have patients that pronate. And what's really interesting about that is the series of events that happen in this slide are the underlying cause for maybe 75, 80, 90% of what we treat as physiotherapists. What do I mean by that? Let's take a look. So the ankle pronates, okay? Your midfoot collapses. That puts tension on the plantar fascia. As your ankle pronates, the tibia internally rotates. Your tibia internally rotates. And so now what's going to happen is you're going to get this rotational shear inside the knee joint, right? So the meniscus is now getting beat up. The tibia and the meniscus are getting beat up on the femoral condyles. The patella, which wants to track straight, and it's got muscle pull and tendon pull and stuff like that. The patella that wants to track straight in a vertical plane or in a sagittal plane, the knee is going to be moving underneath the patella. The femur is going to be trying to internally rotate underneath that patella, and this can be the cause of patellofemoral issues. The femur is going to internally rotate with the tibia because of muscles, tendons, ligaments, and stuff like that. And as the femur internally rotates, the hip external rotators are elongated. They're losing eccentric control, and the hip external rotators are also abductors. And so if we're losing that external rotation and abduction moment or stabilization of the pelvis, what's going to happen is we're going to get a pelvic drop or a Trendelenburg. The moment the pelvis drops, now the pelvis is moving on the hip. And if that happens with every step somebody takes, that's repetitive microtrauma. Do you think that hip can wear out? Do you think you can wind up with some osteophytes or some bony changes at that hip because of impingement, labrum wear and tear? Yeah, you can. And then with the pelvis dropping to the opposite side, the contralateral side, the lumbar spine will compensate. And if we can talk about Freyet's laws and stuff like that, but the lumbar spine will have to compensate. It'll have to adjust. And so you get this side bending rotation and either flexion or extension in the lumbar spine. And now you have this aberrant movement in the lumbar spine. Can you get irritated facets? Can you get irritated muscles? Can you get irritated discs? Absolutely. And so pronation at the ankle is potentially a big problem. Can these things happen in reverse? Let's say that you have an L4-5 or L5S1 facet dysfunction, disc herniation, or some kind of pain in that part of your back that leads to neural irritation, the muscles that those nerves feed, particularly in the pelvis. So let's just talk about what muscles are fed by the lower back. Your glutes, your hip external rotators, your anterior tibialis, the muscles in your midfoot. And so if we get a problem in the lower back, you can potentially end up with this inhibition of all of the muscles that prevent what you see in this picture on this slide. So if you get something in the low back or the pelvis, like an SI dysfunction, it can cause the same series of events. So understand that this picture can happen from the bottom up, or it can happen from the top down. And that's really important, because by the time this comes into your clinic, it kind of doesn't matter if it starts from the top and has worked its way down, or if it starts at the bottom and has worked its way up. If it's happening, we have to address all of it. Regional interdependence, biomechanics. We have to address the low back, the pelvis, and the hip muscles and all of these things. And so it's a little bit mind-blowing. At least for me, it was when I was first exposed to some of this kind of stuff. It's a little bit mind-blowing, but once you get it and you can start to apply this to the other parts of the body and stuff like that, it's really easy. And it's conveniently, what we're seeing on this slide, like I said, is like 75–80% of the patients that you'll treat for lower extremity issues are going to have something like this. It's very, very common. And it's just a matter of if so many patients have it, it's just different in different patients where they accumulate the most trauma and get the most symptoms. Because this, like we talked about all the different diagnoses and things that can happen with just this same series of events alone. So we'll dive deeper into that in our lower extremity course. So stay tuned for that. So these are some of the things as well that can contribute to what we saw on the previous slide, and certainly can contribute to plantar fasciitis, plantar fasciopathy, or the tarsal tunnel syndrome, where we get some irritation of the nerves at the medial and plantar surfaces of the foot. And, again, the question is it the chicken or is it the egg? So which came first? Did the plantar fasciopathy come first and cause pelvic dysfunction, or did pelvic dysfunction come first and cause plantar fasciopathy? Or did tarsal tunnel syndrome come first and cause issues up the kinetic chain? Or did it start off as a lumbopelvic issue, and now we have this neural irritation at the tarsal tunnel? And sometimes we can answer that question, which came first and which came second, and sometimes we can't. And ultimately, it doesn't matter if you're able to address what you find, and address the whole kinetic chain. So here's an elaboration of what I spoke of previously. So when we look at this kinetic chain breakdown, when we look at this picture, and what are some of the things that happen when this is going on in a patient, here it is. You get midfoot collapse. What does that do? It stretches the plantar fascia. It loads the midfoot. When a patient is pronating and they're ambulating, their great toe is actually abducting. So here's a foot, right? And when that foot puts pressure and pronates and the person goes to walk, what happens to their great toe? Let's say this is the great toe. The great toe is pushed into abduction. This is one of the ways that we get this hallux valgus, hallux rigidus, hallux limitus, bunions, corns, these kinds of things. This is one of the ways that it can happen. Obviously, like super tight, pointy shoes is another, but biomechanically, it's common that it can happen this way. Ankle pronation, it elongates the deltoid ligament, the posterior tibialis, the anterior tibialis are not controlling eccentrically the ankle like they should. Tibial internal rotation, we get the shearing of the meniscus inside the knee joint. Femoral internal rotation is shearing of the labrum, shearing of the joint surface, and certainly can cause impingement at the front of the hip. The hip abductors and external rotators become elongated. You can get tendinopathies there. It's also going to contribute to pelvic drop. And the pelvis is now moving over the femur in a way that the femoral head in a way that it should not be. And that's a source of repetitive microtrauma, and it can beat up or degenerate that hip at a faster rate than what otherwise would be normal. Lumbar compensation can mess with facets, discs, the SI joint, etc. So this is hefty. This is good to chew on, and recognize that all of these things can be related. That's why sometimes when you see patients with chronic hip issues or chronic knee issues, we see so many other problems in the same side of the kinetic chain. Okay. This is saying what we've already said in just a different way. I wanted to kind of make it a graphic. So let's start on the left and work our way right. So the first thing that happens is, look, this is for primary plantar foot pain. All right. So let's say that somebody has foot pain that actually starts at the foot and then it works its way up the kinetic chain. Here's a potential scenario for this series of events. There's some kind of local trauma to the foot. All right. And that could be repetitive microtrauma. Someone goes out and does way too much walking or way too much running. And they haven't done it in a long time. And their plantar fascia can get lit up, or they can pronate so much that the nerves that run there are getting hammered, they're getting smashed, they're getting compressed, and they can become irritated. I have gone out and run way too much after not running for a while, and I have actually irritated my own plantar fascia before this has happened. So after you get this local tissue trauma, now we get pain, either the nerve or the plantar fascia, posterior tibialis, whatever. Something is now affected, something's now hurting. What happens when we get pain? We can start to compensate. And this compensatory gait pattern, pronation we talked about, it can lead to breakdown of other components in the kinetic chain, up the kinetic chain. So primary, I would call that a primary plantar fasciopathy or a primary foot problem, where the problem started at the foot and it's worked its way up. There's also the secondary. So a secondary plantar fasciopathy or tarsal tunnel syndrome happens when you get a proximal dysfunction, something that happens in the low back, in the pelvis, in the SI joint, or in the hip, okay? And now that causes that chain of events that we saw in the picture, right? That kinetic chain breakdown, the compensations, and the compensations from the top down lead to the tissue trauma. And it leads to overpronation and all these things that we've talked about, which is going to cause what? Pain, swelling, inflammation. And then that, that pain leads to compensation, and we start moving in ways that we should not, and tissues can get beat up, or tissues can get irritated, affected, damaged, lower down. So I just want to make that clear, because I think that if you pay attention to the patient's subjective history and to their symptoms, a lot of times you can determine where it started. But again, that's not that important, because we want to make sure we just address all of it. By the time we get the patient, it all needs to be addressed. Here's some of the structures in the 1-inch window, as promised. So where the white arrow is going to be roundabout where Baxter's nerve, which is a first branch of the lateral plantar nerve. Where the black arrow is, that's where your plantar fascia originates, and that's where we would palpate for the windlass test. Where the red arrow is posterior tibialis tendon and deltoid, where the pink is where the deltoid ligament would be. Where the purple is, that's your Achilles. Your Achilles comes down and has this fascia that extends kind of to the heel and maybe under the heel just a little bit. The green is where your abductor hallucis originates from. And the blue would be like where you can potentially get pain from, like a heel spur and stuff like that. So just keep in mind that there's so many structures in this kind of 1-inch, 2-inch window that can contribute to pain in our patient. And so we want to teach you guys through palpation and through special tests and through having on your thinking cap how to differentiate what it is. Okay. And why is that important? Why is that important? How do we treat? This is going to be a question that I want to see answers in the chat box. Okay. So you guys get ready to type in the chat box. How do we classically treat plantar fasciitis. All right. So if you asked a PT on the street, how do you treat plantar fasciitis? What will they say? What do you guys learn in doctorate of physical therapy in the United States? What do you learn in your BPT in India? We've got a medical student that's attending. So how have you been taught or trained or educated to treat plantar fasciopathy? I don't want the good answers. Okay. I don't want the good answers. So I'm seeing myofascial release. Okay. Oh, thank you. Ultrasound, myofascial release, and stretching. What else? Come on, we can do better than that. What about ice bottles? Do you guys do ice bottles? Positional release for tender points. What about ice bottles? What about night splints, laser? What's MCR? Mary Victor. What is MCR? Sorry, if somebody else knows, they can tell me. I don't know. Intrinsic. Yes, let's get those intrinsics going. We need the bottom of your foot to have a six-pack. Let's get it.
Yeah.
Microcellular rubber. I have no idea what that is. Ball rolling, towel squeezing, laser. Yes. Orthotics. Yes. Okay. I have the answers I need. Calf release. Yes. Ice. Yes. Okay. So cool. So let's talk about some of this stuff. I have all the answers I need to make this to flip this conversation completely over like an omelet. All right. That's great. Ball rolling, icing. Thanks, Sonali. Okay. You guys ready? All right. Let's jump out of the chat box now. Extracorporeal shockwave, diathermy. This keeps getting better. You guys are really great. This is fantastic.
I mean, this is what we have been doing for years. So it's
10 May, you get extra credit. I'll talk to you later. Okay, we're going to jump out of the chat box. We're going to jump out of the chat box now. Okay. This is why this is important. So plantar fasciopathy versus, let's say that the patient does have either a primary neural issue or a secondary neural issue. Okay. If there's neural involvement, I don't care. Maybe the patient has true plantar fasciopathy and they have neural involvement, or they only have neural involvement that's masquerading and presenting as plantar fasciopathy. Here's why this matters. So the things that we would do for plantar fasciopathy might be ice. We might give a rigid orthotic to prevent pronation, right? To try to protect the plantar fascia. Ball rolling, foot intrinsic exercises. We're going to do a lot of local things, maybe some myofascial release. In the USA, some people use night splints, which is like the special thing that you wear to bed, and it kind of keeps your calf in a little bit of a stretch and your plantar fascia in a little bit of a stretch. So the problem is, if this is a nerve problem and you miss it, everything that we're doing is not going to help. Why is ice not going to help a nerve problem? Because irritated nerves hate ice. Irritated nerves are already hypoxic. They have less oxygen. They're ischemic, they're hypoxic. They have less oxygen and blood flow than they want. And if you put ice on an irritated nerve, it's going to hate it. What happens if you take an irritated nerve and you put in the foot, you take an irritated nerve in the foot and you put a rigid, hard orthotic underneath that nerve that's already getting compressed and it's already irritated and it's already hypersensitive, and you put a rigid orthotic under that nerve? How many of you have had patients that were given orthotics and they said, I cannot wear these, it hurts too much? I've had a lot.
Just to add here, I think what evidence says is that especially for the medial plantar nerve, evidence says that one of the common factors or one of the causes of medial plantar nerve entrapment is medial orthosis. So if you put if you give an arch lift or like a medial orthosis, it can be a causative factor for a medial plantar nerve entrapment.
Yeah. And then, another thing that we know about nerves is, let's say a nerve is involved. Okay, you have a radiculopathy or we've got an irritated nerve at the foot. It's already ischemic or hypoxic. It's getting less oxygen and blood flow than it wants. Okay. And if we put on like some kind of night splint, which is going to immobilize the foot during the night, that's going to impede blood flow and circulation to a nerve that's already wanting more oxygen and more blood flow. And now you can see that if it's neural involvement, we have to check. We have to check where that nerve comes out of the low back and pelvis. Because if there's a primary issue in the low back or pelvis, or even a secondary issue, it doesn't matter. If these symptoms are being contributed to from the back and the pelvis, if we don't touch the back and the pelvis, doesn't matter how many towel curls, doesn't matter how much shock wave, how much diathermy, laser, stretching, exercising, it doesn't matter how much you do, because you're just talking to the messenger and you're not talking to the problem. Okay, the problem exists elsewhere. This is a phenomenon that we know and call double crush. There can be double crush, there can be multiple crush, but a double crush is when we've got a problem at the spine, whether the patient has symptoms there or not. It's not up to the patient whether or not there's a problem there or not. They can say, I don't have pain there. I don't care what they say. As a physiotherapist, you've got to check proximally. If you're dealing with the nerve, if you're dealing with even just pain on the bottom of the foot, you ought to at least check the dermatome and myotome segment in the spine, and just see if there's anything going on there. Because the odds are, if you go to the back and then you find issues, L5, S1, S1, S2, L4, L5, and if you find issues there on the same side, that we may need to treat that. That may be important. And I would say 99% of the time it is. And so I think the take home, the take home is if what you're doing is not working, you may need to check somewhere else. But I'd rather you guys not find out 6 visits in that your treatment's not going anywhere. Ideally, in the first session or 2, we need to screen pelvis, lumbar spine, the nerve. I like to check the regional interdependence on day 1. I like to do bigger picture on day 1 and then hone in on what I feel like the problem really is. It would not be wrong if you're a newer PT, or if it's just a lot of information, it would not be wrong if you want to start locally on day 1 with your assessment and treatment, as long as within the first session or 2-3 sessions, we go ahead and take some time to check up the kinetic chain. You need to do that. And I promise you, 9 times out of 10, you are going to find stuff that needs to be treated, that needs to be addressed. Okay. So this is a little bit redundant. We're going to get into some of the testing and stuff like that, but just going to simplify it back out, for the intents and purposes of today's lecture. We're not trying to get too hot and heavy into the 1,000 differential diagnoses that are possible with foot pain in this area. The 2 most common would be plantar fasciopathy and an irritated nerve. Call it tarsal tunnel syndrome, call it, Baxter's neuropathy, whatever you want to call it, an irritated nerve. And I would say, in my experience, it's more common that it's an irritated nerve, either by itself, that's masquerading and pretending to be plantar fasciopathy, or a situation where you're dealing with a bit of both. If you have a primary nerve issue and we've got these compensations, these movement impairments, these movement problems, pronation and all this stuff, it's only a matter of time before the plantar fascia gets irritated. So can you guys see how a low back issue combined with foot pain that's there because of a hypersensitive nerve, because of what's going on in the low back, and that same origin of the nerve where we've got irritation is that segment feeds our hip external rotators, our intrinsics of the foot, our hip abductors. And so if those muscles get inhibited and we get this kinetic chain breakdown, you have a primary low back issue, kinetic chain breakdown, neural pain at the foot. If that goes on for long enough and the patient is having the kinetic chain breakdown and getting this pronation, midfoot collapse, overstretching the plantar fascia, every step they take, it's just a matter of time before a primary low back and nerve issue becomes a secondary plantar fasciopathy. And let's use the term plantar fasciopathy because plantar fasciitis is a term that the research doesn't really support anymore. When they do tissue samples of the plantar fascia, they don't really find inflammation or inflammatory factors. And so it's more of an apathy. There's a problem with the tissue, but it's not necessarily inflamed. I'm not saying that never happens, right? Like if we have someone who goes out and runs way too much and tears up their plantar fascia, yeah, they're going to have some inflammation, but that's not the most common mechanism. A lot of times plantar fasciopathy or pain in this part of the world comes on what? It comes on insidiously. Patient says, I don't know. It just came on out of nowhere. I woke up with it. I've had it for a long time, you know? And that's also a red flag. You know, I think that the human body wants to heal. It wants to get better. And when it's not doing what it should, we have to ask why. Either the diagnosis is not what we thought it was, and we're not treating it accurately. Or there could be some other things going on. There may be, I call it an offending stimulus. There may be something that the patient is doing on a regular basis that is continuing to offend that tissue, that's continuing to irritate that tissue, right? Posture, work, footwear. Oh, I'm going to try not to go on any bunny trails today, but let me just talk about footwear for 1 minute. I have children. I bought my boys some shoes for school. They were Nikes. I was like, yeah, I want my kids to be cool, right? So I bought them Nikes. And my oldest son puts on his Nikes and he's walking in his Nikes in the shoe store. And I'm looking at his feet, and those shoes took these nice 10-year-old ankles that sit in a perfect position without shoes. And they put him into so much ankle eversion and foot pronation. It was disgusting. And I said, I cannot buy these. I said, I don't know what's wrong with this shoe design, but I cannot buy these. If I buy these, I'm going to have to put an orthotic inside it, or I'm going to have to take my knife to the bottom of the shoe and like cut it so that it's straight. I said, what is this? What is this shoe design? So footwear, it's so much footwear, sliders, sandals, different types of shoes and stuff like that. Some shoes don't have good arch support. Some shoes don't. Some shoes will put you in a bad position just by being in the shoe. And so that's something as a physiotherapist to be mindful of for our patients and for ourselves. I think we saw this slide already. So contributing factors as well to plantar fasciopathy symptoms, neural pain in the foot symptoms. What are some things in the subjective report that can help us to make a differentiation? So things that I like to ask for, if a patient comes in with plantar foot pain, I want to know, do you have low back pain? Do you have pain in your buttocks? Do you have any pain anywhere else in the lower extremity? Are they complaining of like sciatic nerve symptoms? Are they complaining of hamstring or calf tightness or cramping? Hamstring cramping and tightness and calf cramping and tightness is not always a muscular problem. In fact, most of the time it's because the sciatic nerve is unhappy and the nerves that feed those muscles are not happy. So when you get hamstring pain or cramping, they don't need to drink more pickle juice. They don't need more electrolytes. They may be dehydrated and need electrolytes, but why would the cramping be isolated to one hamstring or both hamstrings, or one calf or both calves, or maybe only on this leg? Like that makes no sense if you're trying to argue a hydration or electrolyte issue. Makes no sense at all. So just keep that in mind. If the patient has numbness or tingling, and then if the patient says, I've tried some things, my doctor told me to do these things, or I saw these things on the internet and I tried them, but they made my pain worse. Ice, rigid or hard orthotics, night splints, and myofascial release and soft tissue work. If you have an irritated nerve and you try to do myofascial release you know, tough soft tissue work on an irritated nerve, it's going to light it up. It is going to light it up. That patient may not be able to walk out of the clinic. Okay. So subjective report, these are some things to kind of ask your patient. And if even if I have a patient that has none of these subjective reports, I'm still going to check the low back and the pelvis and the sciatic nerve. We need to know. Okay. We need to know, because I don't want to waste my time and I don't want to waste the patient's time. Some tests and measures that are going to be important. The windlass test. Bend back the big toe, and then you want to palpate the origin of the plantar fascia, which is the anterior aspect or the distal aspect of the calcaneus. Okay. And we want to feel pain right in front of the heel. Okay, we want you to feel the plantar fascia, and we want there to be pain right there. Your finger must be right there, because if your finger is a centimeter off to the side, if your finger comes medial, you're palpating nerve and poking at a nerve, and you'll get a false positive. One of the cheats, this is like a clinical pearl. You can call it a cheat if you want to. Like in physiotherapy school, I didn't give a lot of credence to the Tinel's test. Like, to me, it really wasn't that important of a test. And I started doing this before I realized, I guess, that this is kind of a Tinel's test. So we're going to give credit to Tinel, although I don't know if this is how he intended it for it to be used. But look where my finger's palpating in the first picture. Okay. The nerve runs there. It could be confusing. There's other things that run there. So guess what I'm going to do? We're going to follow that nerve along its course. I'm going to palpate first branch of the lateral plantar nerve. We're going to palpate the tibial nerve. We're going to palpate the sciatic nerve and stuff like that. So I want to palpate the nerve in a couple of different places. And guess what? If you palpate that nerve, and on the affected side, it's more tender, it's more sensitive than it is on the unaffected side, you just got some very valuable information. Okay. Doesn't matter if it's plantar fasciitis with a nerve or if it's only the nerve is involved. Okay. That's the take home. Is the nerve involved or not? Because if it is, we need to treat the back and the nerve if we are going to get this foot pain better. Okay. I don't care if it's 20% nerve problem, 80% plantar fascia problem, or 80% nerve problem, 20% plantar fascia problem. It does not matter. If the nerve is involved, we must treat the low back and the pelvis and the nerve. Okay, that's the take home. You can try to reproduce the patient's foot pain by doing slump test, sciatic nerve test. You can even try to make movements in the leg and in the ankle to sensitize for posterior tibial nerve, Baxter's nerve, and stuff like that. In my clinical experience, Dr. Singh, feel free to chime in a second, but in my clinical experience, I have had probably 80 to 90% of my patients that have neural symptoms in the foot like this, their slump and sciatic nerve tests will not be positive. They will be a false negative. And it's something that bothers me. It's something that drives me crazy, but that's why we have to get several different pieces of information. Once in a while, I'll get one that is a true positive, and I appreciate that, and it makes me happy. But a lot of times, for whatever reason, it's very difficult to reproduce those kind of neural symptoms through slump or sciatic nerve test. Dr. Singh, do you have anything to say about that?
No, I think you're accurate. I mean, you definitely have to combine different findings and make it like a cluster of findings. And then, I mean, just remember, test is not good, and slumps is not neither specific nor sensitive for a specific condition. Yeah. So, okay. All right.
So of course, if we figure out that there is neural involvement, that means that we need to check the pelvis. How do we check it? Right. We would observe their gait. We would do static and dynamic palpation. We would check for tenderness at the SI ligaments, check for hypomobility. And then we want a specific diagnosis in terms of what is going on at the pelvis. Is there some innominate rotation? Is there a sacral torsion? If the sacrum is twisted one way or the other, your sacral nerve roots become affected. If the pelvis is not aligned properly, now your low back is compensating, and we've got, side bending, rotation of the lumbar spine, flexion or extension of the lumbar spine. And it's not hard for a disc to get irritated, for a nerve to get irritated, for a facet to get irritated. And so there's so many things about the lumbopelvic region that if there's stuff going on, it can contribute to what we would call in the osteopathic literature a facilitated segment. Medical terms, we might use the term like radiculopathy. And in a radiculopathy, you don't have to have pain from your back to your foot in order for it to be a radiculopathy. You can have pain that only presents somewhere along the course of that nerve. Nerves are like that. Nerves are weird like that sometimes. You can have a nerve that's getting pinched in the neck, but it's only giving you pain here. Carpal tunnel syndrome, 80% failure rate, carpal tunnel syndrome, carpal tunnel release, 80% failure rate. Do you think that's because surgeons don't know what they're doing? Or do you think it's because we might have what's called a double crush? And maybe the surgeons are only treating where the symptoms are, and maybe they're not treating the problem. It's been maybe 8 years since I've treated carpal tunnel syndrome at the wrist. I don't even treat it at the wrist. We go straight to the neck, the CT junction, and we open up the neck and we do our nerve glides, and lo and behold, carpal tunnel syndrome. Lateral elbow pain caused by radial nerve. Medial elbow pain, that's not golfer's elbow. It's not a muscular tendinous problem. Sometimes it's a nerve problem. We have to be able to differentiate. And so this is what we're trying to do for the foot as well. Okay, so we would want to treat the pelvis. I'm trying not to brag or like show off or whatever. I think that our pelvis course, our lumbopelvic SI course, is probably one of the best ones out there in terms of it being thorough, making it accessible, and making it understandable, because it's so complex, it's so deep. And so many therapists just give up on it. And so many therapists say, well, the research doesn't support even talking to our patients about SI joints, so we're not going to assess it. We're not going to treat it. There are some therapists in the USA that take that mentality, and it drives me nuts, because we know that the SI joint is important. We know it can generate pain. We know that these things can become malaligned and cause all kinds of issues. And all you have to do is treat one patient at the pelvis, where you take them from an 8 out of 10 to a 0 out of 10. And guess what? Now you're a believer, right? And so we want you guys to get to see that and experience that as well. We'll need to screen the lumbar spine, subjective report, range of motion, segmental mobility testing. Are the paraspinals hypertonic? Other testing that we can do there that we're not going to get into today. This is just kind of an overview. As far as what we would do for the treatment, we've kind of talked around it so much, but basically we would need to start at the lumbar spine, maybe even higher. Why higher? All right. Let me see teachers' pets in the chat box. Why would we want to treat, manipulate the thoracic spine? Why would we manipulate the thoracic spine for a patient who's having nerve symptoms or adverse neural tension in their leg and foot? Chat box. Why would we want to manipulate the thoracic spine for somebody who's having nerve symptoms in their leg or foot? Compensation, yeah, but that's less of a direct answer than I'm looking for. There we go. Pretty nailed it. Sympathetic neuromodulation effect. Dural tension, I like that as well. I was going for the neuromodulation. So when we manipulate the thoracic spine, research studies tell us when we manipulate the thoracic spine, which is where we have our sympathetic nerve ganglia, right? And the upper thoracic spine holds the sympathetic ganglia for the upper extremities. The lower thoracic spine holds the ganglia for the lower extremities. When we manipulate the thoracic spine and we give it that kind of input, there are objective neurological changes that we can measure in the extremities. Dr. Singh, you're the NCV guy. Do you want to expand on that? Like just maybe elaborate on that a tiny bit?
I will talk about it once you're done. So I think I have some.
Okay, yeah, we'll talk about that in a sec. So as far as the treatment goes, stay tuned for our GEM courses. I'm going to give you guys a summary, and then Dr. Singh's got a couple things that he's going to add. So the summary for my portion of the lecture: perform a robust differential diagnosis for plantar fasciopathy. Don't go the wrong way on the first day. You need to have a high index of suspicion for neural involvement, and not just with this, but with anything that you treat. Screen the nerves that are in that area, please, because if they are affected, then you need to go to the spine. All right, so have a high index of suspicion for nerve involvement. And then if there's neural involvement, the lumbopelvic region must be assessed and treated along with the sciatic nerve. Okay. All right.
Okay.
I think I'm going to turn it over to Dr. Singh. Do we want to entertain questions for maybe a minute or two before we change gears here?
Sure.
Let's do that. All right. So I know Dr. Tanmoy Chakraborty has a question. So go ahead and ask your question. If anybody else has any questions to this point, let's go ahead and ask them. If the questions pertain to, registration, signing up, more information about GEM, I'll direct you guys to our email and phone number at the end of the slideshow. So hang on to those kind of questions. Dr. Singh, do you want to take the question?
I don't think there is a difference, to be honest with you. I mean, manipulations are not direction specific. When you manipulate AP or PA, AP manipulation would be hard on thoracic spine, but if you still try to do it, it doesn't matter. I think what you're doing, the outcome is very similar. You're trying to do a sympathetic modulation. Down regulation is the right word.
Yeah. Any other questions before we jump into the last little bit here, the last little stretch? All right. All right. Well, if there's more questions, we can take them at the end. Okay. Dr. Singh, take it away.
Okay. So what is the sensitivity and specificity of tunnels for Baxter's nerve? Oh, very, very poor. And it has not been studied much. So I'm going to talk about this in greater detail and how we should assess. And that's why combining findings is important. So let's talk about intrinsic factors that can cause or that have shown to have a strong association with plantar fasciopathy. And sometimes these factors or these correlational factors can also guide treatment. Okay. So if a patient comes to you with plantar fasciopathy and you find decreased dorsiflexion, now you should know what manual therapy technique you should use, because decreased dorsiflexion has strong association with plantar fasciopathy. Okay. Increased BMI. Obesity has a strong association with plantar fasciopathy. This patient should be referred to nutritional counseling. Okay. High or low arch. So research says it doesn't matter whether the foot is pronated or supinated, both patients can have plantar fasciopathy. If patient has a true pes planus, we probably need a medial longitudinal arch or some shoe modification. Okay. Dr. Ford, do you mind going back to that slide?
Yes. Sorry, one second.
Yeah, this is good. Yeah. So another very, very interesting factor or correlational factor is leg length discrepancy. And Dr. Ford was talking about SI dysfunctions. He was talking about posterior nominate rotation. He was talking about pelvic outflare. Research says that if you have leg length discrepancy, the leg that is longer tend to have more association with plantar fasciopathy. Okay, so whenever you're seeing a patient with plantar fasciopathy heel pain, you have to find out whether it's true leg length discrepancy or an apparent leg length discrepancy. If it's an apparent leg length discrepancy, you're going back to the SI. And this is all strong evidence for plantar fasciopathy. And then talking about decrease in great toe extension. How many times have you seen, or how many times have you checked great toe extension range of motion for plantar fasciopathy? Research says if the range of motion is less than 65 degrees, I think normal range of motion of great toe extension is 80. If it's less than 65 degrees, you're going to have higher chances of plantar fasciopathy. The idea here is how many times you have mobilized great toe when you're seeing a patient with plantar fasciopathy. Okay, so these things or these strong correlational factors can also guide treatment. I will make sure I will increase the dorsiflexion of every plantar fasciopathy, true plantar fasciopathy patient I see. If they're obese, I'm going to send them to nutritional counseling. If they have a high or low arch, I might try shoe modification or give them an arch. Okay, leg length discrepancy. If they have a underlying pelvic dysfunction, I need to address that. They may have a secondary dysfunction. What Dr. Ford was talking about, secondary plantar fasciopathy. We have to address the SI because it is causing, research says longer the leg, higher the chance of plantar fasciopathy. It can be true leg lengthening or apparent leg lengthening. Okay, I would do some AP glides on my first MTP so that I can gain that toe extension, which is a strong factor with plantar fasciopathy. Okay, and if you look at all these factors, they are actually addressing regional interdependence, because you're treating the talocrural, you're treating the first MTP, you're treating the pelvis, right? And then secondary factors are you're running, usually runners report activity modification can help with plantar fasciopathy, and job that involves prolonged weight bearing. This is also comes under activity modification. I think there's a question. SI dysfunction can cause glute weakness, or glute weakness can cause SI dysfunction. So yeah, that's another strong correlational factor. But this is pure evidence out there. So people who are looking for better treatments for addressing plantar fasciopathy, make sure that you're looking at these biomarkers or looking at these markers, because they have strong correlation. Okay. Dr. Ford, do you mind moving to the next slide?
Yeah.
Yeah.
Any questions you guys have, go ahead and put them in the chat box, and then we'll take them at the end. I think Dr. Singh has only a few more slides, and then we can kind of entertain some questions and stuff. Sound good?
So we're trying to differentiate between plantar fasciopathy and something what is called as distal tarsal tunnel. Okay, so your nerve is getting entrapped distal to your tarsal tunnel. Okay, so patient will usually present with pain with the first step. If patient comes to you and say, whenever I take my first step in the morning, or if I'm sitting for a long time and I stand up, that causes pain. That's a very, very significant symptom of plantar fasciopathy. Okay, pain at the end of the day, if they have a standing job and they've been standing for a long time, that is another very important factor. Research says average time to seek care is usually greater than 1 year. So they have been suffering for a long time and then they come to you later. Okay, tenderness to palpation at medial calcaneal tubercle, positive wind loss test. Dr. Ford spoke about 99% specificity. So very highly specific. You can rule in the diagnosis if you know how to perform a wind loss test. Okay, this is another very important factor. Don't miss out on talocrural, because decrease in active and passive dorsiflexion. For every plantar fasciopathy patient you see next time, make sure that you're checking for dorsiflexion. For both active and passive, you'll always find true deficits there, missing posterior glide to the talus. Okay, and you have to address that even before going up the chain. Make sure that you're addressing talocrural. Okay, Tinel test would be negative for true plantar fasciopathy if you don't have nerve irritation, and if you do ultrasound, you'll find true thickening of plantar fascia. Okay, so these are the symptoms and presentations and signs of a true plantar fasciopathy. All the nerve signs like Tinel would be negative. And we'll talk about the nerve testing and distal tarsal tunnel in greater detail. Getting some questions.
Let's take questions at the end. Before we move on from this slide, I just want to highlight a couple of things. The reason that plantar fasciopathy can masquerade, the reason that it can seem like it's plantar fasciopathy, but it can be something else, is because some of these things will actually have in common. So we've all had low back pain patients, pelvis patients, disc patients. What happens when they get up first thing in the morning? Is the disc better or is it worse? Morning is usually worst. The disc is maximally imbibed, and then they've been relatively static during the night. And so if there's nerve issues and there's stasis and there's not blood flow and oxygenation down the nerve is going to be hypersensitive. And so nerve issue can also have pain with their first step. Nerve issue, if we're talking like discogenic lumbopelvic, if they've sat for a long time and then they get up, you know, those patients that can't straighten up right away, they need a minute to kind of, you know, take some steps and stuff like that. So getting up first thing in the morning, getting up from sitting, and even standing for a long time, those are things that, you know, plantar fasciopathy would have in common with neurological issue as well.
Let's move on to the next slide and we'll have a chat about that. Okay. So these are the secondary impairments that can happen with plantar fasciopathy, and that's why manual therapy comes in handy. The research says most of your patients will have pronated foot and a navicular dysfunction with it and has plantar fasciopathy. Okay, so make sure that you're assessing and treating the navicular. Okay, that's a the navicular whip technique has very strong research evidence in treating plantar fasciopathy. Okay, apart from doing all the passive modalities and soft tissue and MFR and intrinsic muscle work and ball rolling, please check the navicular. Okay, usually you have to mobilize the navicular or manipulate the navicular, and that has really strong evidence. Okay, if your patient has pes cavus, okay, they're loading more on the outside of the foot. Cuboid dysfunctions are very common, so treat that cuboid dysfunction. If your patient has pes cavus, supinated foot, and plantar fasciopathy, true plantar fasciopathy, make sure that you're addressing the cuboid. Yeah. Talocrural dorsiflexion, I can't repeat this again and again. You usually will find dorsiflexion deficits with any ankle foot problem. Either it's tarsal tunnel, distal tarsal tunnel, or plantar fasciopathy. Okay. First, MTP mobility deficits, make sure that you're mobilizing the foot. Assessing the MTP first and then mobilizing it in all your plantar fasciopathy patients, because this is causing all the biomechanical problems, causing the plantar fascia to stretch. Okay, so make sure that you're addressing this. Okay, so let's talk about distal tarsal tunnel. I really like this topic because this is very fascinating. So I'm just going to show you how things work here. Okay, so this is the medial side of the foot, and people were asking, okay, this is the medial side of the foot. So you have the tibial nerve that comes behind the medial malleolus, right? And then it divides into the medial plantar and the lateral plantar. Okay, and lateral plantar gives a small branch called Baxter's nerve. Okay, interestingly, if there is a compression of tibial nerve behind the medial malleolus, right, that is called tarsal tunnel. Okay, and if there's an entrapment of medial plantar, we call it jogger's foot. Patients who are pronators, they do repetitive eversion or have like an arch, medial arch support, this nerve can get entrapped. Okay, so make sure that you're looking at all these specific nerves, because this is very important. And usually patients will present with very clear symptoms. Your medial plantar nerve entrapment patient will present with burning like symptoms on the first, second, and third toe. Okay, your Baxter's nerve patient can also radiate pain to the first, second, and third toe, but they will present pain more like plantar fasciopathy, but the symptoms will be more like burning. The interesting thing here is Dr. Ford was talking about Tinel sign. We can do Tinel on the tibial nerve. We can do Tinel on the Baxter's nerve, but lateral calcaneal nerve is not accessible to Tinel. And that's an interesting. And when you do Tinel on tibial or Baxter's, symptoms can radiate either proximally or distally. And that's an interesting finding, because that's how you differentiate between a nerve problem or a plantar fascia problem. Because when you do like a Tinel on the Baxter's nerve, on the inside of the foot, you will see some local radiation of the nerve, a local radiation of the symptoms. Baxter's nerve is a mixed nerve, so it can give you some sensory component and some motor component. So you can either have like some dull achy pain radiating or some numbness and tingling. Okay, and that's a very, very important point, because that if you know how to palpate it and touch it and just do a little bit of a tapping on the Baxter's nerve, you can actually differentiate clearly, because plantar fascia symptoms should not radiate. It's the fascia. So anything you want to add, Dr. Ford?
Nope.
Okay. Do you mind moving to the next slide?
Yep.
A little more high-end stuff. Okay. So ideally, if a patient goes to a primary physician or a podiatrist for heel pain, they usually look for a heel spur, right? That's the norm. They usually look for a heel spur. Heel spur has a poor correlation. Heel spur on a radiograph has a poor correlation for both plantar fasciopathy and distal tarsal tunnel, because normal folks also have heel spurs. So,
Yeah,
but that's what medical doctors do. They just do a X-ray and they say, oh, you have a heel spur, so you have a plantar fasciopathy. So that's not the right way to do it. You can do a nerve conduction test on abductor hallucis muscle to find entrapment of medial plantar. Okay, because medial plantar will show you prolonged latencies to abductor hallucis muscle. Lateral plantar, on the other hand, will show you some latency for abductor digiti minimum, which is on the outside. I can't say this again and again. The best way to find it is patients will have burning pain and palpation will reproduce symptoms. Okay, and obviously you can do dorsiflexion and eversion, SLR. And that is usually positive, but in certain situations it may not be. So the idea is good, strong history taking and physical findings is the gold standard diagnosis. Okay, to differentiate between a distal tarsal tunnel and plantar fasciopathy. Okay, you can do a tunnel to the abductor hallucis and that can reproduce symptoms. Symptoms can be up the nerve or down the nerve. Okay, there's a question there. I think we'll take this question at the end. Dr. Ford, do you want to move into the next slide? I think this is the last slide. Okay. We'll take more questions now. So let's answer this question. Sir, is this need to treat separately? Or? I think you need to correct both local and regional dysfunctions, because we know that locally you can have a talocrural problem, you can have a navicular problem, you can have a cuboid problem, you can have a first MTP problem. That's what research says. So you'll first treat things locally, rule out the nerve irritation, and then go up the chain. Okay. Research also says that apparent limb length lengthening can also cause plantar fasciopathy, right? So definitely assess the pelvis and hip and also the musculature around it. Okay. Any more questions, guys? Dr. Ford, do you want to add anything?
No, I don't.
The idea here is that regardless of where you start, either you start at the pelvis or you start at the foot, you address both. Okay.
Yeah.
You're addressing going from distal to proximal or proximal to distal. It's sometimes hard to say what came first. I mean, even with like a robust history taking, it's hard to say that symptoms started in the pelvis or hip first and then progressed down the chain or progressed up the chain. Yeah. Half circle manner. So there could be many causes. I mean, you can have, of course, plantar fasciopathy. You can have any soft tissue lesions or soft tissue xanthomas or stuff like that. Or you can have a classical tibial nerve entrapment around tarsal tunnel, right? If you go down, you can have a lateral calcaneal nerve entrapment. You can have a medial calcaneal or medial plantar nerve entrapment. You can have Baxter's neuropathy. Yeah. Those are the more important ones. You can have ligamentous involvement, but that's not very common. Deltoid ligament doesn't get involved that often, but it's possible.
Got to watch out for insertional Achilles tendinopathy as well. And
You can have a retrocalcaneal bursitis. I think you have a small bursa on the medial side of the tendo Achilles, or that can happen too, but it's not super common.
All right, guys. Any other questions? Okay, one more.
What would be symptoms of true proximal tarsal tunnel. So we're talking about tibial entrapment here, talking about posterior tibial nerve entrapment or tibial nerve entrapment. You'll have symptoms of numbness and tingling on the medial side of the foot. Yeah. And if you have a double crush, you have a proximal tarsal tunnel and it has progressed. In certain situations, I mean, if the tarsal tunnel has progressed in the later stages, you can have involvement of distal tarsal tunnel, and you can also have weakness of abductor hallucis and abductor digiti minimi, and that is in later stages. Okay, so you have involvement of both tibial, medial plantar, lateral plantar, and Baxter's neuropathy. So, what is the role of fat pad atrophy? I think that's just a biomechanical change. I don't think there's any strong evidence correlating this to plantar fasciopathy, but this is. So, talking about calcaneal spur, this is what evidence says. A lot of medical doctors, they rely on radiographs to see a calcaneal spur to diagnose it as plantar fascia. That's what medical doctors do. They would, if somebody comes to them with a medial plantar fascia type symptoms, they would do an X-ray, and if they find like a calcaneal spur, they say this is plantar fascia for sure. But the research and evidence has shown that people with no symptoms, asymptomatic patients, also have calcaneal spurs. Okay. So that's why history taking and physical examination and understanding the problem is very important. Just relying on a radiograph is not the way to go about it. Spur influences heel pain. There are a lot of false positives. So no is the answer here. So
if you've done everything else and nothing else is happening, and the patient does have a spur, and that spur is painful to deep palpation and walking without shoes and stuff like that, you kind of need to make sure we address everything else first, because I forget what it was in the research study, but it's like as many as 80% of people that have bone spurs don't have symptoms in the heel. Like there's a very high percentage of people that do have heel spurs that don't have pain or symptoms from it. And so, yeah.
So just relying on heel spurs, that's why evidence comes in handy. Do you mind going back to the previous slide? Just go to that strong correlation for plantar fascia slide. Just go back a little. Yeah. Go back. Yes. So yeah. So I think this slide is gold, because I think this gives you all the factors that causes plantar fascia, and this could also guide your treatment. Okay. Yeah. Should I be treating dorsiflexion? Yes, absolutely. If I have a patient I know that increased BMI causes plantar fasciopathy, should I be sending this patient to nutritional counseling, encouraging them to lose weight? If I know that pes planus or pes cavis causes plantar fasciopathy, should I be addressing that? Absolutely. Leg length discrepancy, longer leg means plantar fasciopathy, right? Should I be addressing the pelvic dysfunction, SI dysfunction? Yes. And this is all pure research evidence, strong evidence. Decrease in grade 2 extension. How many patients have you seen where you had heel pain but you're working on the first toe? I can promise you that none of us, including me, would work on grade 2 extension in patients with plantar fasciopathy. But we should, because there is a strong association with it. Okay. So the research and evidence should guide treatment, not our foundational knowledge. This piece of information should guide our treatment. What will be the sacral dysfunction? I think ideally, what I've seen, anything that causes apparent limb lengthening, like outflare or posterior nominate, usually presents with heel pain. And that, I mean, even research says that longer the leg, more chances of plantar fasciopathy. Posterior nominate rotation or pelvic outflare both causes the leg to become longer, apparently longer. Okay. Then there was one about abductor. How would you treat that? I think abductor hallucis, that is medial plantar nerve entrapment. How would you address the medial plantar? Why medial plantar nerve is getting entrapped? We have to figure out that. Okay. Any more question, guys? Any running in prolonged well-being, how influences heel pain? Yeah, so the activity modifications. If you're treating a runner and he continues to report pain with running, sometimes slowing down, giving them rest is important too. So that's why activity modification is also. Apparent limb lengthening means apparent limb lengthening means going from posterior outflare, posterior nominate rotation is lengthening, anterior nominate is shortening. Okay. I think posterior nominate, we call it like apparent lengthening. That's what we call it, not shortening. Anterior nominate we call it apparent shortening. Treatment for foot stamp during, is the dry needling treatment for symptomatic relief? Doctor, that's a good, interesting question. Dr. Ford, have you done any dry needling on plantar fascia?
So I have had, 99% of the time, I fix plantar fascia without dry needling. I have some patients where the symptoms might be stubborn, or some patients where they might ask me to try dry needling. They say, oh, I've heard about this, I'd like to try it. And, you know, I would never do it on a first session. You know, the first 2 or 3 sessions, I want to see what our manual therapy and neural, you know, treating the adverse neural tissue tension and stuff like that, addressing the big problems. And then from there, if we decide to get into some dry needling, yeah, we might. I know a lot of people that would do dry needling all along, like sciatic nerve, hamstring, calf, posterior tibial nerve, and in the foot, and then run electrical stimulation through those needles to try to affect positive change. So I think it just depends on what your, you know, what your lens is. And for me as a manual therapist, I like to address, you know, if there's an underlying problem, if the nerve is unhappy, and there's an underlying problem why the nerve is unhappy, then I want to treat that underlying problem. And you can do what you want to, but just in my mind, it makes more sense that if we've got an unhappy nerve, we need to treat it at the level of the spine, at the level of the pelvis. And then dry needling would potentially be an adjunct. I don't think you would be wrong if you did dry needling, but if all you did was dry needling and you did not address lumbar, spine, and pelvis, then you would be missing out. You would be missing out. You'd be missing potentially the cause or a very large contributor to these symptoms.
Okay, I think this is my take on this question. I mean, so if you look at the research and evidence, I mean, they don't talk about dry needling a whole lot, but I think a lot of dry needling comes from like acupuncture and other foundational sciences like Chinese medicine and stuff like that. So they have been using dry needling to needle your calf muscles for like plantar fasciopathy, right? I think that's what AMT teaches. They like to needle the calf muscles for plantar fasciopathy. So, but I mean, if you look at the research and evidence, I think it's the role of dry needling in plantar fasciopathy and evidence and research is missing. But in like Chinese medicine and acupuncture, I think they have been needling the calf muscles for plantar fasciopathy. But needling as itself is not a great modality. If you are combined with different other modalities, treat the talocrural, treat the navicular, cuboid, and treat problems up the chain. Then I think, and then you can needle it. I think it will be more effective. Yeah. Any more questions, guys? Okay, I think that is it. I think Dr. Ford is teaching a lecture on saphenous.
On saphenous nerve. I think there's a bit of confusion, I think, in the terminology, TJ, because when we do the supine to sit, we're looking at posterior nominate as appearing to be short, and then when they sit up, it appears to be long.
So, I mean, you have to look from the standpoint of heel, because which is assessing symptoms. If you do a posterior innominate rotation, what will it cause the, what will happen on the posterior aspect of the leg? Okay, because you have to think from that standpoint. When you do out, when you see out flare, what will happen on the posterior aspect of the leg? Yeah. Recalcitrant chronic peroneal pain. So it should,
Yeah,
are you talking about lateral foot pain or lateral leg pain?
like peroneal tendon, like peroneal tendons, or peroneal nerve, like fibular nerve. Probably peroneal tendons, like multiple ankle sprains or like a trauma.
Lateral leg pain. It's like you're talking about distal or proximal.
Like closer to the knee or by the ankle. Yogita. Okay.
Not responding to LFS mobilization, needle sliders. I would assess the SI. I think that is what causes the lateral issue usually. I would assess the pelvis. I mean, I think that's it's a more likely it's a pelvis issue. SI has a strong radiation pattern to the lateral leg. Okay, and I think there's a lot of research done by Gleaming. He talks about how lateral leg pain has a crazy strong evidence with SI pain, not responding to peroneal tendon inflammation treatment. He's talking about peroneal tendon. I think it is because of weight bearing mechanics. I think you have to address the weight bearing mechanics here. Check the SI and see what you find in SI dysfunction. Okay.
Okay. Yeah, I think let's go ahead and wrap up the questions for now. Thanks, guys. Thanks for joining in. Thanks for actively participating and stuff like that. And we want you guys to connect with us. So if you get a chance, connect with us on any or all of the following. We want you guys to, follow our Facebook page for cool information. And, we're going to be putting out 3 more free lectures. Next weekend, I'm going to be teaching something similar. We're going to be talking about mysterious medial knee pain and how the saphenous nerve can be something that can give us knee pain, but you can't fix it at the knee. We would have to fix it at the lumbar spine, the pelvis, and the hip. And so it's very interesting. It's actually been something that's helped me with many, many, many patients. It's very common. We're trying to treat things that are common, that are very useful. They're common, but they're not commonly known. They're common, but they're not commonly known. Or as another therapist used to say, this condition has seen you, but you have not seen it. In other words, you've seen many, many, many patients that have had saphenous nerve involvement, whether or not you saw it, diagnosed it, confirmed it. So anyways, next weekend, saphenous nerve, it's going to be really interesting. You guys tune in. We look forward to having you again. And you guys should reach out for more information on our courses, on our certificate program. We're looking for experienced therapists to apply to us to potentially become mentors and go through a special training program with us. We want to raise up a group of mentors that we can use to potentially go on and teach GEM lectures for us, potentially house GEM students that are trying to get, are we calling them fellowship hours, or do we have any terminology for that?
Yep, fellowship hours.
We want to develop a fellowship program in which our students that finish up this certificate program can go on and get hands-on training with somebody who really knows what they're doing. And to me, that makes a big difference. It's similar to the fellowship program that Dr. Singh and I did. You finish it, and then you don't have to go and do the hours. But if you want to be considered a fellow, if you want to complete the fellowship, then you spend hours under another therapist who is giving you feedback, helping you with your manual therapy techniques, helping your clinical reasoning and stuff like that. So it's really cool. Yep, guys, look forward to having you. I'm going to sign out. We will catch you guys later. Thank you so much.
Thank you for your time.
Thank you.